Welcome to this video of management of dyslipidemia. In this video, we will basically talk about the recent guidelines which is given by the American Heart Association, ACC, and American Diabetic Association 2024. I have just summarized all the complex things into simplex things. So let's begin. At first, we have to know about the ASCVD score. ASCVD score. It means that atherosclerotic cardiovascular disease score. It estimates that what is the percentage of having the cardiac events like stroke or heart attack in next 10 years. And in this we use some parameters like these are the parameters which we use in calculating the ASCVD score. These are the age, sex, race, total cholesterol, HDL, LDL, systolic blood pressure, diabetes, either patient on hypertensive or not, smoking status, and aspirin use. It can also be written as like HBLA for understanding. I write as HBLA. It means H for heart, B for brain, L for leg, and A for aorta. So in this, in heart, what can happen? There can be MI, there can be angina, there can be any coronary events, and in brain it can be ischemia, it can be ischemic attack, or it can be stroke. Similarly, in the leg, the events can be like peripheral arterial disease or any type of limb ischemia. And in aorta, there can be atherosclerotic aortic aneurysm. So basically this ASCVD score is one of the rough it is the rough calculation of having cardiac events or this mentioned events in the next 10 years. So we have learned about ASCVD. Now moving to the summarize guideline. So we basically choose the statins groups of drug for the management of dyslipidemia. In statins, we choose one is the atorvastatin, another is the rosuvastatin. So we write as atorvastatin and rosuvastatin. And we choose the as moderate intensity statin and high intensity statin. So for understanding of those, I simply write as moderate intensity statin, moderate intensity, and high intensity. So for simply, I write doses like rosuvastatin 5 to 10 mmHg, and this is 10 to 20 mmHg. And again this is 20 to 40, and again this is 40 to 80 mmHg. So this is basically the dose. This is in mg. So this is the dose which use as low intensity statin and high intensity statin for atorvastatin and rosuvastatin. Now we have to know that what are the indications for choosing the high intensity statin and low intensity statin. So for choosing high intensity statin, there are some criteria which we should follow, that if the value of LDL is more than 190 mg per dl, then irrespective of any age or any other condition, we have to start with the high intensity statin. That is, high intensity statin is atorvastatin this and rosuvastatin this. And again, if age is between 40 to 75 years, then if there is ASCVD risk, if there is ASCVD risk more than 20%, we have to start with high intensity statin. Similarly, if there is any evidence of clinical ASCVD, then also we have to start with high intensity statin. Similarly, if there is diabetes mellitus with multiple risk factors, or ASCVD, diabetes mellitus with ASCVD more than 20%, then we have to start with high intensity statin. Similarly, for the moderate intensity statin, there are also some criteria for which we should follow, like if LDL value is more than 70 mg per dl and ASCVD risk is more than 7.5 to 20%, we have to start moderate intensity statin. And again, if age is 40 to 75 years and patient is diabetic mellitus with LDL value more than 70 mg per dl but without any high risk patient, any high risk. If there is high risk, we have to start with high intensity statin, but if there is if there is no any high risk, then we have to start with moderate intensity statin. And the third is if age is more than 75 year and patient is with clinical ASCVD, and patient is with clinical ASCVD, we have to start with moderate intensity statin. So while comparing these two, if LDL is more than 190 mg per dl, we have to directly start with high intensity statin. But if LDL is more than 70 mg per dl and clinical and ASCVD risk is 7.5 to 20%, we have to start with moderate intensity statin. And if the patient is having clinical ASCVD, it means the patient is having any of these conditions, and age is between 40 to 75 years, then we have to start with high intensity statin. But if patient is having clinical ASCVD but age is more than 75 years, then we have to just rely upon this moderate intensity statin. Now we have to know about some things about the statins. So in statins, it's basically mechanism of action is that it is one of the HMG CoA reductase inhibitor. So what basically it does is that there is HMG CoA which gets converted into mevalonate by the presence of HMG CoA reductase. So what statins do is that it just inhibit this step, and so that mevalonate is not formed. And basically this mevalonate is actually later getting converted into cholesterol. So basically statins inhibits this HMG CoA reductase so that mevalonate is not formed, and finally cholesterol is not formed, so level of cholesterol gets decreased. And what also it does is that it increase the LDL receptor. So if it increases the LDL receptor, then it causes increase uptake of LDL, due to which degradation of LDL cause increases. If uptake is more, then degradation is more. Then if degradation is more, then LDL value gets decreases. It means cholesterol is decreased. So this is the mechanism of action. Now some it's adverse drug reaction. So it's adverse drug reactions is basically I remember as HMG. HMG, which means that S for headache, S for headache, M for muscle weakness, M for muscle weakness, and G for GI symptoms like nausea and vomiting. So these are the side effects. And S for also is hepatotoxicity, hepatotoxicity. So this is the adverse reactions and mechanism of action. Now while giving statin, we need some monitoring. We have to do monitoring. So let's talk about monitoring. So during monitoring, at first, before starting any statin therapy, we go for a fast, that is fasting lipid profile. Fasting lipid profile. The patient is actually fasted for around 8 to 12 hours. Then at morning we take a full fasting lipid profile, and again it is taken after around 4 to 12 weeks after starting therapy. Usually around 6 weeks. Usually around 6 weeks of starting therapy, we again repeat the fasting lipid profile. And if the patient is stable on therapy, if patient is stable in therapy, then it is checked every 6 months usually. So if patient is stable, we check every 3 to 12 months. In simple, we check usually 6 months. So easy to remember, like 6 weeks and 6 months. This is easy to remember. And while monitoring, what we look for is that there should be more than 50% LDL cholesterol reduction with high intensity statin, and aim for LDL cholesterol reduction is less than 70 mg per DL in very high risk ASCVD patient. What I am telling about this monitoring is taken from Davidson. Actually we do one of the test is a fasting lipid profile, and second what we do is a liver function test. Liver function test is also done before statin therapy, and it is usually not repeated. But if the patient is having symptoms like dark urine, if patient is having symptoms like dark urine, jaundice, then we check for LFT. And if ST or ALT level, rises to more than 3 times, of upper limit of normal, then we basically stop this statin therapy. And also we check for muscle symptoms monitoring. Actually it is not done before starting statin therapy, but if the patient is having any family history of any muscle weakness, or personal history, then or also if patient is treated with fibrates along with statin, then we check baseline before starting statins. But if patient is not having these conditions, then we are not going to take muscle symptoms monitoring before starting statins therapy. And during therapy, there is no need of monitoring of this muscle symptoms monitoring like CK. But if the patient is complaining symptoms like muscle weakness, and then we check for the creatine kinase, and if its value is more than 10 times of upper limit, then we basically stop the therapy. Along with this, also we check for the diabetes mellitus monitoring. So these are the 4 monitoring which we do during the management of dyslipidemia. Hope you have understand well. I have just summarized the guidelines, and informations are from Davidson in the ACC AHA and ADA 2024 guidelines. Hope you enjoyed the video. If you liked it, then please share to your friends. If there is any problem with understanding, then please mention on the comment. If there is any question or queries, let me know. And please subscribe the channel. Thank you so much.